Okay, thank you very, very much. I'm absolutely thrilled to be here and talk about a topic that has been the passion of mine my entire career as a genetic counselor. In full disclosure, I do work for a commercial diagnostic laboratory and work very closely with the Colorado genetic counselors. And before joining Myriad and moving to Colorado, I was an academic counselor in Houston, Texas. So I've had a wide range of kind of exposures and experiences dealing with how to appropriately collect and evaluate family history. So the objective for this talk is to increase collection and use of family history to ensure appropriate risk-based cancer prevention, messaging, screening, and referrals. So family history is a major, major clue to cancer risk. And by using family history and in conjunction with genetic testing, we can really do an effective job stratifying patients by risk. So either general population risk, needing general population screening strategies. The highest risk are people who have inherited cancer mutations. And to give you an example, patients who have hereditary cancer risk may have cancer risk as high as 87% for breast cancer and BRCA1 carriers compared to 10 to 12%. In the general population. They need very, very different screening and management strategies than the general population. They need to start younger and have more intensive surveillance, and in some cases, risk-reducing options. We also know that even if it's not hereditary, if there's no gene mutation identified, family history can still influence screening practices, so they may be somewhere intermediate between the management options for hereditary and general population risks. And so what we really need to do is make sure that providers in multiple different areas, so oncology, women's health, primary care, are taking an adequate family history of cancer. But also that's not enough. They need to be able to evaluate that family history, understand the risk factors, and know what to do to follow up with that information. So the problem that we're trying to address is that we know that hereditary cancer is underdiagnosed. So based on information from my company, who is the sole provider of BRCA1 and 2 testing and a major provider for Lynch testing, which are the two most common hereditary cancer syndromes, we estimate that something like 1.1 million people who have Lynch syndrome or a BRCA mutation are still undiagnosed in this country. I have less specific data for Colorado, but we do estimate that somewhere between 40 and 120,000 people just within the Denver metro area alone have risk factors for hereditary cancer but have not been tested yet. We do have very, very good data on the number of patients in Colorado who have ovarian cancer who have not been tested. So ovarian cancer is an indication for BRCA testing that's been in place since 2008. As of 2013, only 30% of all individuals with ovarian cancer have been tested for BRCA. And we know that that's not a result of patients not wanting to be tested. There's studies indicating that close to 90% of patients with ovarian cancer want to know their BRCA status. So there's something happening in the system that's not connecting these patients to the services. There's also been several studies that have found that as many as 71% of all medical oncology offices are taking insufficient family histories, typically not including ages of diagnosis. And so having that family history is very, very key to appropriately identifying these patients. There's multiple different ways that we can measure success in this area. So I think, as we had mentioned, collection and use of family history by different types of medical providers is one thing, but also uptake of genetic counseling services and genetic testing services could be another. The reason why we want to prioritize this work is that there's something that can be done to reduce these cancer risks. So for example, patients at high risk for breast cancer benefit from a lot of different things, including increased screening, which doesn't reduce the cancer risk, but it can detect it at an earlier stage when it's more treatable. But there's other options that can actually reduce the risk. Similarly, we have options for ovarian cancer, colorectal cancer, and endometrial cancer, which form the bulk of diseases that we see in hereditary cancer syndromes. And furthermore, if we can identify the proband or one person in the family who has hereditary risk, each of their children has a 50% risk. It was usually inherited from either their mother or their father. And so oftentimes we can identify multiple people within the same family once we've identified the proband. So hereditary cancer is rare, but there's a significant percentage of the oncology population who have risk factors that would benefit from an appropriate conversation. So that's all outlined in the materials that you have. And so for example, we think that something like 37% of all breast cancer patients have risk factors that deserve a conversation about hereditary risk. And then again, population stratification of risk is going to be very helpful so that we can tease out the highest risk patients and give them appropriate intervention. But also for families where there's a known mutation and a relative test negative, they have no increase in cancer risk and can stop cancer screening, and that can save, or go back to general population screening rather, and that can really help save healthcare dollars. Okay, any questions?
Tell me about the proband again.
So ideally, what would happen for hereditary cancer risk evaluation is you start genetic testing in a member of the family who's had cancer, and specifically an early onset cancer, one of the major red flag cancers. And the idea is that if you identify a mutation in that person, you know exactly what's causing cancer in the family, and you can just test for that one mutation in relatives and give them a yes or no answer whether they inherited it. If they did, they're at high risk, they can go into prevention and screening strategies. If they did not inherit it, they can go back to general population. The other thing is that if the patient with cancer is negative, we can't always rule out an increased risk for other family members because we don't know of all the genetic factors that cause an increased cancer risk. But it suggests that whatever technology that we have today is not able to detect what's causing the cancer in the family. And so then we don't need to test all of the other relatives because we don't know what to look for. And ovarian cancer is so key because about 15% of ovarian cancer is hereditary. So if we don't test that ovarian cancer patient and know what her status is, and she passes away, we know that based on guidelines, her first and second degree relatives are all now eligible for a comprehensive test. And so that increases healthcare costs if we can't test the ovarian cancer patient first.
Thanks for that. You're dear to my heart. I have a question about how, as a task force or as a coalition, we can measure an impact in this area. You mentioned that you have some data about the number of patients with ovarian cancer that have been genetic testing. But if the outcome, I guess what would be the outcome that you'd like to see? Is it increased referral to genetic counselors? If that's the case, how can we measure that systematically over time to see if we've been having an impact? Or is that really not the goal? Is the goal to identify hereditary syndromes and get to their families? Or just how does this fit into something that we could both make an impact on and then measure the impact?
That's an outstanding question. I think that, ideally, I think what we would measure is the number of patients who have hereditary cancer who are participating in interventions that reduce cancer burden. I think that's ideal, but I don't think we're quite there yet. I think there's a number of things that we could do on a number of different levels. So at a provider level, we could estimate or measure the number of healthcare providers who are capturing an adequate family history, and we have definitions of what that means from ASCO. We could measure knowledge of guidelines for genetic counseling referral among those healthcare providers. We could measure the number of healthcare providers within the state who are appropriately and routinely referring to genetic counselors. We could measure increase in referral to genetic counseling. I think, the challenge there is we, would have to really get a lot of buy-in from genetic counselors to help us measure the increase in appropriate referrals. Or we could also measure it based on genetic testing uptake. So we know that it's not so much in Colorado because there are so many genetic counselors, but there are providers besides genetic counselors who are doing genetic testing, so that could be another measure.
I'm going to let Randy add something really quick on that measure.
So the program that I mentioned this morning, the Public Health Genomics program that the Cancer Registry was funded for, is actually going to be engaged in a lot of this type of work. So part of what we're doing in the registry is we're going to be figuring out how to collect family history in a more meaningful way, and then also reaching out and working at a systems level with providers to help educate and maybe help them deal with their EHRs, and how to take that information in a more meaningful way. And then we're also planning, if we can, to collect information about the number of people that have been referred for counseling and then possibly the number that have been sent on for testing. So that's part of some of the work that we're going to be doing under our new program. And then also I just wanted to let everyone know that we were successful in getting a couple of questions added to the behavioral risk factor surveillance system for the 2016 survey. And so we're going to be asking the number of adults who discuss their family's history of cancer with a healthcare provider, and then the number of adults with a close family member diagnosed with breast or colorectal cancer who are up to date with their modified screening recommendations. So we'll have a little bit of information coming out of BRFIS on those points.
And I will be here for lunch, and I also want to recognize Jessamine Nasario. She's a genetic counselor at Sally Job. So we will be here for lunch, and Jessamine will also be here tomorrow. So please come and talk to us if you have any other questions.